Hello to everyone. Welcome to the ASRM webinar on telehealth during the pandemic and beyond, a tool for your clinical arsenal. I am Sarah Ramaya, curriculum designer at ASRM with my colleague Jessica Goldstein. Joining us are panelists Dr. Lauren Berman, a clinical psychologist in private practice in Atlanta who specializes in reproductive psychology, third-party reproduction, and psychological trauma. She is the chair-elect of the ASRM Mental Health Professional Group and a founding board member of the Jewish Fertility Foundation. Brooke Bumpers is an attorney in the Washington, D.C. office of Hogan Lovells LLP, where her practice is focused on healthcare. Among other issues, she's been advising clients on telehealth for well over a decade, including issues related to licensure, coverage, reimbursement, and liability. Amy Vance, a genetic counselor and founder of the Bay Area Genetic Counseling. Amy has been providing telemedicine for over 20 years. She provides genetic counseling to couples and egg donors all over the country. Dr. Serena Chen serves as director for the Division of Reproductive Medicine at St. Barnabas Medical Center, the Institute for Reproductive Medicine and Science, as well as clinical associate professor at Rutgers Medical School. She graduated from Brown University and Duke University School of Medicine, trained in gynecology, obstetrics, reproductive endocrinology, and infertility at the Johns Hopkins Hospital. Before we begin, please note, all attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the panelists during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I will now turn this webinar over to our first panelist, Dr. Berman.
I will use the next 10 minutes to get you up and running with your telehealth practice. Sometimes just getting started is the greatest barrier, nothing to disclose. I'd like to welcome you all to my teletherapy office. Appointments can be booked online, and yes, I'm not wearing my shoes. I'd venture to guess that the attendees are seasoned professionals who have received massive amounts of training in medicine, law, counseling, etc. However, most of you have little or no training specific to telehealth, and telehealth requires a different skill set. This webinar is the start, but I would encourage you all to get some training. There are things that we need to think about when we're embarking on telehealth that we don't need to think about when we're in our offices. One of the things to think about is your own comfort level with technology. If you are not comfortable with technology, this may not be the best modality for you. We also need to think about the patient's comfort level with technology. Unfortunately, this is a variable over which we have very little control. What does the camera show? And where are you sitting? Is it your garage? Is it your bedroom? And how professional does this look? How do we make eye contact like we do in our offices? This is a very important part of doctor-patient interaction. And those of us who have experience using video conferencing platforms know that we see a little video of ourselves when we're interacting. This can be really distracting, and how do we make use of this? What do we do with this? So let's get started. First, I recommend using a HIPAA-compliant video conferencing platform. FaceTime and Skype are not HIPAA compliant, and Zoom has recently had its issues. Other speakers will talk at greater depth about the importance of HIPAA compliance. But technology freezes. If you have an Ethernet connection, that's actually the best for video conferencing. I don't have one, but I do have a high-power Wi-Fi connection and a little device called a Wi-Fi booster or range extender. When we're examining a patient through a video screen, we want to see them clearly. Therefore, having a large monitor or screen helps. I use my laptop screen, but some people use large monitors. Using a smartphone can be really limiting, but it will suffice in a pinch. We also need to think about sound quality. Sometimes your computer microphone is sufficient, but typically I use an external microphone that I plug in through a USB port. Some people use earbuds or AirPods, and for this particular call I'm using my smartphone and a microphone. We need to turn off background programs. It's best to actually reboot your computer before the video conferencing session, but a lot of background programs buzz or ding, and then they also make the technology more prone to freezing. And then we want to have a professional background so that we're projecting as if we're in our offices. This is going to be harder to have a professional background while we're sheltering in place, and it's also harder to have a quiet, private place. So we just do the best that we can. There are some helpful tricks of the trade. Tom Ford, a fashion designer, sent some tips to New York Times columnist, and I've included two of the most helpful in this slide. Most importantly, prop your computer up on a stack of books so the camera lens is just above eye level, and then point it down into your eyes. That gives you the ability to see the screen while making eye contact. Second, lighting makes a difference. Take a lamp and place it next to the computer near the side of your face that you feel is best. The lamp should be in line with and slightly behind the computer so that the light falls nicely on your face. Other tips from Ford are placing a white tablecloth on the table in front of you in order to reflect the light, and using face powder, which I guess that's a makeup tip that I don't know much about. After having some difficult moments where my telemental health patient met me from a Starbucks, I developed an instruction sheet to help my patient set up the session so that we can mimic an office environment. I've included a modified version of this form in the webinar handout packet. Many of the directions I provide are the same as those that I gave you in your startup guide. I also need to know what state the patient will be sitting in so that I know whether I am licensed to practice in that state. Physicians and nurses have had interjurisdictional compacts in place for some time so that they can practice across state lines, and psychologists recently had one approved. However, not all states participate in these compacts, and it's important to do your research ahead of time. We also ask patients to bring a photo ID to the session and refrain from using their employer's equipment and Wi-Fi. Employer equipment is often monitored by the company, and this can create a big challenge for privacy. In addition to these instructions, I ask patients not to record their sessions, to check with their insurance companies about telehealth coverage, and to understand that technology can distort the interaction or it can fail. It's important that patients have a plan B, a backup plan, so that if the technology does fail, they know how to re-engage the session. This slide is a bit more foreboding than I intended, but it's meant as a caution to help us think about ethics and guidelines before we embark on telehealth. All of our professional associations have ethical guidelines, and many of them have separate guidelines for telehealth. These are the most relevant ethical principles to telehealth practice. Patient welfare, also called beneficence, competence specifically in telehealth, informed consent, confidentiality, financial disclosure, and documentation. Starting with beneficence, it guides us to think about whether telehealth is the most appropriate modality for each patient. For example, in fertility counseling, we have the technological capability to do some gestational carrier screening by video conference. However, some of the things we are trying to assess, namely the resources, stress levels, financial coercion of the GC candidate may actually be severely impacted by the pandemic. And we need to ask ourselves, is now a good time to assess this GC candidate, or should we wait until after normalcy returns? Clearly, there are also physical examinations that will not be done by telehealth. We need to consider what might be gained and what might be lost. And are you competent in telehealth? If not, training can be obtained from a variety of online sources. These are some sources. I'm not recommending any of them in particular, but they're some of the more popular training sites, and you can access them through the internet and do all your training online. You'll need a separate informed consent document for telehealth. And the document will include much of the information I've already reviewed, along with express permission from the patient to authorize electronic transmission of health information. And again, it may not be the best for each. Confidentiality and HIPAA must be factored in. HHS has put out a document stating that they will be lenient with HIPAA violations during the pandemic. But confidentiality is not just a legal requirement. It also impacts doctor-patient trust, which is critical in treatment. So before you use a non-HIPAA compliant platform, think about how it will impact trust. And don't forget to document that you're doing telehealth in patient notes, reports, and billing. Telehealth has the potential to reopen the world for us and for our patients. It provides accessibility to highly specialized professionals. It's cost-effective. It's convenient. But it's also a modality that requires significant changes from in-person practice. So before you embark on telehealth, seek formal training, get help from a technology consultant, have your attorney create and review forms, learn what your ethical guidelines say and what state laws and insurance companies say. What are the limits of the liability that you're assuming? Consider the best interest of the patient. You can do this. You can step outside your comfort zone as long as you're creative and willing to.
All right, thank you, Dr. Berman. Over to Brooke Bumpers.
Thanks. Good afternoon. This is going to be just a very high-level overview of some of the legal issues to consider when you provide telehealth services. I'm only going to be able to touch on a few of these topics. Although there are some waivers and short-term exceptions that have been put into place to facilitate greater access to telehealth during the COVID-19 pandemic, I'm going to start from the pre-pandemic perspective and then make note of some things that have changed. So these are just a few of the topics that I'll touch on. So one of the biggest challenges, particularly for multi-state providers of telehealth services, is licensure. Now, this may not be an issue if you're just providing services to your patients who live in the same state you do, where you're licensed. But if you live near a border area and you're now, living and practicing in different states, or your patients who normally come to your state are across the border in a different state, or if you want to see patients in multiple states, you're maybe providing services across the country, the general rule is that you need to be licensed in the state in which the patient is located. And so for some health professionals, getting licensed in additional states isn't that difficult, but for physicians in particular and some other health professionals, it can be costly and time-consuming, not only to obtain multiple state licenses, but also to meet all the requirements and keep track of them for maintaining your license. As Lauren mentioned, there are some states that have entered into these interstate compacts that allow that if you're licensed in one of the states, it's relatively easy to get licensed in others, but not all states participate in those, and it depends on the particular licensure category you're in. Some states do have exceptions and special telehealth licenses, but not a lot do. And again, it's state specific. One other thing you need to be mindful of is that different states have different categories and names and qualifications and scopes of practice, particularly in counseling and behavioral health fields. So in one state, you may be qualified to be licensed as one thing, and in another state, you may fit into a different licensure category with a different name, or you may not meet all of that state's requirements for the same license that you hold in another state. So again, these are all state specific. And as Lauren mentioned, patient consent is important. There are some states that specifically require informed consent to receive telehealth services, and you may need to inform patients that they have the option of receiving in-person services instead. Now, I know that for many ART services, patients have to pay out of pocket, but for services that are going to be billed to third-party payers, you need to be mindful of the fact that their coverage of telehealth services may differ from whether and when and for whom they'll cover in-person services. So you can't just assume that something that you have been doing in your office and getting paid for by a third-party payer will also be covered if you do it by telehealth. So if you plan to bill a payer, you need to make sure you know that the services that you're planning to provide by telehealth are covered and under what circumstances, and also what the reimbursement rate will be and what your patients will have to pay, because those can all vary payer by payer. You also need to know whether a particular payer has certain requirements regarding the technology used to provide telehealth. Typically, they do require real-time audio and video interaction, but there are some variations, and as we'll mention, there are some exceptions in place at the moment. So there's a pretty wide variation in payer policies regarding telehealth, so you just have to be mindful of that and not assume that because you got paid for something by one payer that another will as well. Lauren touched on the issues of HIPAA and privacy, and I'm not going to go into a lot of detail. It's not my particular area of expertise, but telehealth encounters are covered by HIPAA, just like an in-person encounter. So you do need to be mindful of patient privacy and data protection. And telehealth poses some additional risks regarding data protection and data security. And then separate from HIPAA, you also need to be aware of particular state privacy laws. And some states have very stringent ones. As Lauren noted, in general, you should make sure that the technology platform that you're using is HIPAA compliant. And if you're providing services outside of a healthcare setting, that you make sure that you're in a situation in which you can maintain the privacy of your communications and your documentation. And you may need to enter into a business associate agreement with the technology partner that you're working with. Liability concerns. You really want to make sure that your liability insurer knows not only that you're providing telehealth services, but also knows where you're providing them. So you can make sure that you have coverage for what you're doing. You can't assume that the coverage that you have that covers you in your office will necessarily apply if you're doing telehealth services, and particularly if you're providing telehealth services in multiple states. Otherwise, you may be assuming that you have coverage, and in fact, you may not. So we've been talking primarily about kind of the status quo of telehealth. Under the COVID-19 pandemic, there have been many states and many federal waivers and alterations of certain rules in place. A lot of states have waived or altered their in-state licensure requirements to either allow out-of-state physicians to practice in the state without being licensed, or they've otherwise removed certain licensure requirements temporarily. But these, again, vary from state to state, and you need to check the specifics if you plan to provide telehealth to a patient in a state in which you aren't licensed. Many payers have also taken action to expand coverage of telehealth and to make it more accessible. In particular, many payers are allowing patients to receive telehealth services at home who may not have otherwise. But again, you need to check each payer's policy to know what is and isn't waived at the moment. And at the end, I'm going to give you some resources for where you can access some of those state-specific exceptions that are in place. And then as Lauren sort of referenced before, the Office for Civil Rights, which enforces the federal HIPAA rules, has announced that during the COVID-19 pandemic, they will, what's called, exercise their enforcement discretions for providers who are making a good faith effort to provide telehealth, even if they're using technologies that may not be fully HIPAA compliant. So at the moment, that would include things like FaceTime or Skype. So these are just some resources that may be helpful to understand not only the telehealth legal landscape on the federal and state front currently, but there are particularly some lists of waivers and exceptions that may be in place in your state at the moment. And I think, the big question, which I think speakers that are coming after me will talk about, is, whether or not some of these temporary waivers and temporary expansions of telehealth, which are on their face in place only for the COVID-19 pandemic, will in fact prove to be so popular and to work so well that some or many of them will remain in place for the long term. So that's a stay tuned for more. We don't know yet, but I do believe that this is a bit of a tipping point for telehealth. So now I'll hand things off to our next speaker.
Hi, thanks for joining us. This is Amy Vance. I have no disclosures. So I'm going to talk about about genetic counseling in the fertility setting, focusing on my experience in performing genetic counseling remotely. I'm going to give you some tips and show some examples about how to communicate complex information with the assistance of diagrams to help patients understand. So my clients are couples, intended parents, choosing gamete donors, and also gamete donors themselves. And typical indications for patient referral include family history evaluation, gamete donors, couples, or intended parents, both to ensure that the gamete donor meets ASRM criteria for her family history, and also to determine whether there are any specialized tests that might be indicated based on family history for any couple or gamete donor that's referred. Other indications include positive genetic carrier tests, counseling, family history of genetic disorder, mosaic embryo counseling, chromosome translocation carriers, and male or female factor infertility. And genetic counseling is well suited to telemedicine. I have a lot of experience in providing remote genetic counseling. I find it to be quite a good setting for patients. As Lauren mentioned, it makes it very accessible, it's very convenient, time efficient. It allows the counseling session maybe to be scheduled sooner, and therefore allows the recommendations to be provided to the referring physician sooner, which is very important to fertility patients. So I generally use a landline office phone. I usually do not use video conferencing. As Lauren mentioned, it's important to make sure that you have a good headset or speakerphone quality. I usually begin with a casual chat or introduction to establish rapport with the patient. I start with family history because it's a familiar topic for people, and it gives me information that can help me to understand the patient's background or prior experiences leading up to the consult. It's important to consider things like the pace and the language that you're choosing. It's ideal to avoid things like medical jargon so that patients can understand what you're talking about more easily. Genetic counselors are trained in discussing difficult topics in plain language, and so that comes easily to me. And with time, you'll develop intuition as the conversation is going about cues that a patient either has a question or isn't understanding what you're saying. This could be something like a pause or a question or a statement that they're asking that misses the mark. It's important to check in frequently, especially after you talk about maybe a complicated topic, just to make sure that they're understanding. And so for certain more complex topics, I share pictures with the patient in advance, and then we talk about them together on our call, and I'll give you some examples of those now. So this is a picture demonstrating autosomal recessive inheritance, And so as an example, I would have sent this picture to the patient in advance, and then we would go over it together at the same time. So I would typically use a diagram like this with a couple who were both carriers for a mutation in the same gene and were at risk for having an affected child. And so there would be a lot of background that was given that I'm not going to talk about now, but we would, I would have explained that we have pairs of genes and that carriers of recessive disorders have one normal gene and one mutation. These are represented, the normal gene, by the white side of the person, and the blue side would be representative of the gene mutation. And in this picture, both parents are carriers. And so each parent would only be giving one copy of each gene to their offspring. They would either give the white or the blue. And so there are 4 combinations shown below that would be the possible outcomes for their offspring. If each parent gave the white, that would be an unaffected child, which is shown on the far left. The next 2 possibilities are where one parent gives the mutation and the other the normal gene, and then the reverse. That would be a 50% chance to have a carrier offspring. And then the last chance, they both give the gene mutation, which would be the 25% risk for an affected child. If I'm talking about the possibility of a mosaic embryo transfer, I will use this picture. It's a very good visual for patients to understand what mosaicism is. I described using this picture that a mosaic embryo is made of cells that have both normal chromosomes and cells that have abnormal chromosomes. And in the picture, the abnormal cells are represented by the black and the white are the normal cells. This is a representation of a chromosome translocation, a reciprocal translocation. And when I'm talking to patients that are carriers for translocations, in the beginning, I will discuss normal chromosomes. On the left-hand side is just kind of a picture showing the arrangement of chromosomes, that chromosomes come in pairs. And then on the right-hand side is a representation of a chromosome, a reciprocal chromosome translocation. And we would talk about the different combinations of chromosomes that an embryo could inherit and the outcomes of each. So having reviewed that each parent only would give one copy of each pair of chromosomes, they would either give, for example, the blue chromosome with the orange on the left, or the normal blue chromosome on the right, and the same for the pair of orange chromosomes. And so as an example, this parent with the translocation, if they gave the blue chromosome on the left and the orange chromosome on the left, then the resulting offspring or gamete would have too much orange and too little blue. And then we would go over each gamete possibility and what the outcome would be for that embryo. For another webinar, probably, there are many other forms of communication. I use the telephone. There are text messages, app-based access, patient portal, social media, website, all with different pros and cons or different utility from other medical professionals. Thank you so much.
Hi, I'm so excited to be here. My name is Serena Chen, and I've already learned a lot from our other speakers. So I really appreciate being here, and I think we can all learn from each other. I'm from New Jersey, and I hope you follow me on Instagram and Twitter so we can talk about telehealth and medicine and COVID-19 and fertility a lot more together. So I have some disclosures. So I am not wearing shoes, but I did take a shower and I got dressed for you guys, and you'll see later that I wore my lucky sperm necklace. So I hope you appreciate that. So I have some questions for the audience. I really want your participation. I really want this to get you revved up about this, because I am asking myself every day, why did it take a pandemic to get telehealth reimbursed? And I think we heard from our other panelists a little bit about that. Like Brooke was talking about a lot of the legal barriers and the concerns about HIPAA. And but this begs the next question: why should we go back to the dark ages after the pandemic is over? And of course, I want to touch on some practical tips for being super awesome as a virtual doctor. So this is my personal email address, Dr. Serena H. Chen. You got to include the H for high maintenance at gmail.com. If you are not getting reimbursed, or if you see any emails from insurance companies, any official correspondence saying that they might end telehealth, they might stop paying for telehealth, because I do think it's important for us to be proactive and organized now. I'm working with AMA and some other organizations, hopefully ASRM, ACOG as well, and all of healthcare providers to say, you know, telehealth is good for us, it's good for our patients. We should continue to be paid for this. So telehealth breaks down barriers between patients and providers, and it acknowledges the value of our brains. So we're gynecologists, we use our brains and our hands, but our hands are much better reimbursed than our brains. And I don't necessarily think that's the way it should be. It shouldn't be that we should get less reimbursement for the surgeries that we do, but we should get more reimbursement for our thoughts and our knowledge and experience. Telehealth is less intimidating for patients, and we all, dealing with fertility patients, we know how intimidating this is for patients. There's data showing that more than 50% of people that are struggling with infertility actually don't ever come to see the doctor. And coming to the doctor is a big deal. By the time the patient gets to your office, they've already overcome a lot of emotional barriers. They've gotten in their car, they've driven in New Jersey, they drive on the Garden State Parkway, which is kind of life-threatening. Then they have to deal with parking. Then they get to the office, and by that time their bladder is full, and they want to save their urine just in case you need it. So they are super uncomfortable on a both emotional and a physical level. Telehealth is obviously much more convenient for them, especially the first time they're meeting you. They don't even know if they're going to like you or not. Telehealth is ideal for improving patient knowledge, education, understanding, comfort level, and compliance. And we all know that all of those things lead to better outcomes, which leads to healthier patients, happier patients, decreased morbidity and mortality, and lower cost. I'm not sure the insurance companies realize that, but they really should. So the number one doctor in the United States today, and probably around the globe right now, is Dr. Google. And Dr. Google did not go to medical school. Why is Dr. Google the leading authority? Because Dr. Google is accessible, and we are not accessible. If you make your patient pick up the phone between 9 and 12, then you take a lunch break, and your phones are closed from 12 to 1, and then after that, you're only open for 2 hours, and you don't use Facebook, and they can't message you, they can't email you, and they can't reach you. That's why they call Dr. Google. And that needs to change. And that's on us, and it's on society as well. There's multiple forces involved, and we need to do our part to make healthcare more accessible for our patients. And telehealth is a big part of that. So more practical things. Okay, I'm done venting, but I could vent forever. So research your platform. Free is not always better. This guy is looking at his patient, and either you have a new virus or my computer does. And I had a lot of these issues today, so I definitely am feeling this. And I appreciate a lot of the practical tips from our other speakers. So you need support, okay? You're a physician, you're doing complicated things. You do still have to maintain privacy. And so you, just using a free app, that might not be the best thing. It needs to be easy, not just for you, but also for your patient. The platform has to be stable. We're seeing a lot of instability in these platforms because they're scaling up so quickly, and some of them are able to scale and some of them are not. You also need to have a platform that's flexible. They should be able to use their laptop, their tablet, or phone. And I tell you, we're using a platform, and we do enormous amounts of education with our patients ahead of time, and we give them numerous instructions. They don't follow any of the instructions, so you need to have a flexible platform. I tell everybody they need to use a laptop. They get the handout, they get text messages, emails, use a laptop. They all show up on their phone. I'm looking at a couple. I can only see half of their faces, but we make it work. You need to have flexible time and scheduling. You need to have audio backup, and you need internet security in general for your whole practice, your EMR, and your telehealth platform. And the HIPAA BAA is quite important. And I think Brooke already mentioned that HIPAA BAA. So these are some examples. I am not endorsing any one of these platforms. These are just a few of the ones that I'm familiar with. And so they're just examples, so I can give you concrete examples. I will tell you, Eric Hayden, who has a telehealth company, he just did a nice video, two nice videos, things on medical economics that I thought were helpful. So those are nice things. You can go on medicaleconomics.com and check those out. Right now I'm using, I put Clara at the top because yesterday that was my favorite platform because I was using it, but Clara this morning had a lot of issues. So I do like Clara. I'm using Clara. I've used Doxy.me. A lot of people very excited about Doxy.me. Seems super easy and it is free, but it does seem maybe perhaps overloaded and not good if there's more than one practitioner. Anymeeting.com is a platform I've used for meetings, and then we've transferred it over to telehealth. Doximity. I would urge all of you to sign up for Doximity. I think this is a doctor thing, so all doctors can sign up for Doximity, but then all your nurses can use your name to sign up. So I think you just need your NPI number. Doximity is a great platform because it has a lot of great articles and communication, and you read some of the articles, you get free CME credits. You can also use the dialer, which I love. The dialer allows you to dial from your cell phone. It blocks your personal number, and it puts up on the patient's cell phone, it puts up your whatever you want. So I put up my name and my practice number, and this has totally changed my life. Instead of using *67 to call my patients and then having them not answer because they think I'm a robo dialer and then playing like phone tag forever, which is so annoying, I use the Doximity dialer and my patients pick up right away, which is super awesome. My nurses are loving it too because they all signed up under my name and they can put on their phone, Mary see me, and the patient's like, oh, that's my nurse, she's calling me, I'm going to do that now. Doximity has just launched a beta for video, and love to hear from you guys if you've tried it. I've tried it. It's still obviously beta, not so easy to use yet, but hopefully they will do more. And then, of course, there's Zoom, there's Skype, there's FaceTime, there's Google. A lot of these platforms, you can do a HIPAA BAA if you pay for the service and you do the professional level service, but the free service, often you cannot sign a BAA. And Zoom, everybody loves Zoom for these meetings, but I don't know if you guys have been in some of these like lodestone technology meetings with ASRM guidelines and the Wuhan and Italian OBGYNs giving us advice, lots of attendance, including Zoom bombers. And some of the Zoom, like the other day I was on the one with Resolve, and there were hundreds of attendees, and then suddenly the chat was overloaded with thousands of swastikas. It was a little bit scary that these people were bombing in on the conference. So this has been happening more and more often, and that's one of the issues with Zoom. So HIPAA BAA, Health Insurance Portability and Accountability Act Business Associate Agreement. So apparently if you sign this with your telehealth platform, then if there's some security breach and PHI or private healthcare information, the patient information is released, and privacy is invaded, then apparently it's on them and not on you. But obviously I am not a lawyer, so do not take my word for this. And as Brooke said, like a difference between states, you have to talk with your liability carrier, all of those things. So I wanted to show you some of these platforms. This is Doxy.me. So on the left, the screen is from my smartphone, and you just go to Doxy.me, and this is the screen you get. And then you just press that little button in the middle, and then the next screen is what you see on the right. And my cute little face is up there, and there's a link, and you press the button and you send the invite, and then the patient gets the invite, and boom, you're on a video call. And supposedly this is HIPAA compliant. It's designed for healthcare. We tried to sign up for it because it looked really cute and free, but they wouldn't answer the phone because I think they're so popular they can't get to the phone right now. But a lot of my friends that really didn't have telehealth platforms through their practices were able to use this and liked it. This is Doximity. So in the middle, that's my cute little picture at the bottom. The big picture is my IT guy. And that's what it took to get on the phone. So I tried this with a couple patients a few days ago. because I use the Doximity dialer all the time. I was very excited about the video call option. And when you press this little video button right here, it does say video call is in beta. So they're obviously still developing things. Then you get this little text messages, then you press this link, and I thought I would be connected to my patient, but I really wasn't. And I had a tech-savvy patient who was only 25 years old, and she tried it with me, and we both ended up in separate video rooms, not able to see each other, but apparently there's another button you have to push, and then you get to be in the same room like me and my IT guy here. So this is still being developed, but I am very excited that people are developing these things, and I love Doximity for other reasons. But again, they are not paying me for anything. Anymeeting.com. So I've used this for years. This we use because we have 8 offices and a lot of employees, and sometimes we want to talk to all of them at once, and Anymeeting is great for that, because this is like, a lot of these platforms, it's only you and your patient. Like, what if the patient's husband is in another location, or the patient's partner is in another location, and you want to bring the 3 of them together? A lot of these platforms are not able to do that. Something like Anymeeting, Zoom can do that, but then Zoom has its own issues. Anymeeting.com, it can be used for healthcare. They will sign a HIPAA BAA agreement, but they do cost money. We have been using them. We've been using them a lot for our employee meetings. You can have 16 little faces on the screen, so it doesn't have as big a capacity as Zoom, but it has been working well for us, and we do use this for video consults. It's not as easy to use as Clara. Clara is a little bit more user-friendly, so we've been using this a lot more, but again, you can only get 2 people onto a Clara video conference, and today I did have a lot of connectivity issues, but in general, I've been using this for years for secure HIPAA-compliant text messaging, so I can text blast all my patients. Please call your nurse. We are doing virtual visits, or all patients are canceled tomorrow because of the snowstorm, except for retrievals. Please call the office. So I can blast to the whole practice any patient who is registered with Clara.com. And we make all our patients register. And there is a function, if people cannot receive text messages, Clara will convert our text messages to a voicemail. So patients that cannot do text message can get a voicemail. And it's on both Android and iOS. But the other thing is they just recently started a few weeks ago, their video platform, and the video platform has been working really well. And we also use this for social distancing. So we're running a once a week OB clinic, for the urgent people, and we have people text in remotely from the car, and that's been really, really helpful. Okay, so this is Clara.com. But basically this is what you're looking for. I should erase the Clara.com because this is what you're looking for in your platforms. And, like being able to text and message and easily schedule and also document. That's the other thing about HIPAA compliant healthcare platforms, unlike Zoom, is that, although maybe Zoom does do some documentation, but we feel like the documentation here is really, really good, which is great for billing and for liability. And the Clara doesn't appear to need a lot of internet speed, although today I did have to use my Doximity dialer while I kept the patient on video in order to get sound. So, there's no platform that's perfect, and I think a lot of it has to do with scale. And I think they're getting better every day. And I'm very excited that we have all this technology available to us. So bottom line is, this is the same as when you talk to the patient. And in some ways it's better because maybe you're a little more relaxed and maybe the patient is a little bit more relaxed. You're both a little bit less distracted. And I really loved it. This has been such a wonderful opportunity to really connect with the patient and do counseling and education. Ask the patient to take notes, and then, at the end, make sure you have a clear plan for follow-up. My nurse is going to call you. My nurse is going to email you. The insurance counselor, she's going to call you and email you. She'll look into those questions about, your visit. And I give my patients homework assignments. I'm like, well, now you're going to take your vitamins and you're going to eat more vegetables and you're going to, sleep 7 to 8 hours a night. And we're going to start a home exercise program. And by the way, I'm sending you videos and consents to sign and all of those kinds of things. And I did talk to somebody about quitting smoking this morning. Okay, coding. This is the big thing, is that now, as Brooke said, the laws have changed, at least for the pandemic, and telehealth can be reimbursed. And that's why we're getting all this cool technology scaling up. So very important to document the modifier negative 95, huge. That makes video consults basically exactly the same reimbursement as in-person consult. That is my understanding of the law. And now that we've been doing it for a few weeks, we are actually seeing that. I have to say, the first week I submitted all my claims for video consults, they were all rejected by Blue Cross Blue Shield. And we called them up and said, listen, what's going on? Because we were getting ready to report them to the state. And they said, oh, that was a mistake, just resubmit. So now I am getting reimbursement. So this is really small writing, but this is all in your handout. This slide and the next slide, all really small writing. It's all in your handout. If you guys have any questions, you can just email me or send questions to the webinar. They'll forward me the questions. So that's good. I think really cool to know that your nurses can also do telehealth. And that can really be helpful. Nurses in the fertility world, obviously, we know, are highly trained, highly experienced, very valuable, and a huge partner in our care. And you should be reimbursed for all the work that they do. Remember that telehealth consults with the doctor are not the only way to be virtual. You can do all your training, all your IVF and IUI training. Right now, I use Engaged MD. There are probably other platforms. A lot of practices do their own videos. A lot of pharmaceutical companies do a lot of great videos for medication teaching. We've been with Engaged MD for a few years now. We really like them. They include the DocuSign component into the classes, and it's nice that they document that the patient attended the class and did the DocuSign. So it's really been helping with informed consent. And the videos, actually, the patients are mostly giving them good reviews. They seem to be very engaging, and they're mostly getting good reviews. It's not quite as engaging as Ozark Season 3, but it is, for a fertility patient, most of them are really watching the whole video. So that's nice. I'm also loving that genetics can be done totally remotely. Like, we could all have this capacity before the pandemic started. We did blood work because people don't seem to like to spit very much, but now people are really getting into spitting now that they're stuck at home. So saliva kits are super popular. Like, I cannot tell you, when I tell people I'm mailing you a kit and you're going to spit in the cup and then you're going to get these genetic results, people's faces light up. It's just the coolest thing. And I have to tell Amy, I've already met Amy virtually, and I think Amy should start doing video consults, because Amy, I think that's amazing that you do phone consults and you can explain those things to patients. But as a physician, like, I only know like Gregor Mendel and his P's, like, took me 30 years to even be able to say uniparental disomy. So I think Amy should start doing video consults. That's my personal feeling. And maybe we should advocate, Brooke, for better reimbursement for video consults for genetic counseling. They definitely need to get better reimbursement given everything that they know and what they do for us. In the future, I'm hoping for home COVID-19 antigen and antibody testing in order to get accessible, widespread testing for the entire population on, it sounds like maybe a frequent level, because it's going to be with us for a while, that we need to be doing virtual COVID testing. And what about home hormonal levels? And what about home pelvic sonograms? I would love to talk to somebody who's interested in that. I envision like a little disposable vaginal transducer. Everybody knows how to put in a tampon, kind of like that. And you press a button on your phone and it downloads all the photos, sends them to your doctor. Those sound kind of crazy, but I bet you in a few years we might actually be talking about that. Okay, so why should we go back to the dark ages after the pandemic is over? Again, please communicate with me. Please follow me on Twitter and Instagram. Let's work together, because we deserve to be paid for our brains and not just our hands. We should be compensated for our time and advice, not just physicians, also genetic counselors, also nurses. Telehealth makes healthcare more accessible, and access to care improves outcomes. And, you know, this is what we want. We want better things for ourselves and our patients. So I do think virtual medicine in some ways can be better than reality, although I hope I meet all of you in person in a real meeting in person someday. And again, my name's Serena Chen. Please follow me on Twitter and Instagram. Don't forget there's an H for my middle name. And I look forward to meeting all of you in person soon. Thank you.
Thank you, Dr. Chen. We will now open up the floor to questions for our panelists. Please send in your questions through the question chat box located in the gray toolbar. Jessica Goldstein, over to you.
Thank you very much, Sarah. The first question I have is for Ms. Bumpers. What are the security issues surrounding video telehealth visits? What is the clinic's liability?
I was afraid I was going to get HIPAA questions. That's not really my area of expertise. There are specific HIPAA rules on security and data protection. I unfortunately can't go into that here, but I would urge you, if you're engaging in this, to get some legal advice, not only on HIPAA compliance, but making sure that you're complying with applicable state laws, because there are some states that have very specific state level requirements.
Thank you. The next question is open to all the panelists because I think you have different opinions. Is there a benefit to using video telehealth versus a phone consult? Why don't we start with you, Ms. Vance?
Sure. Well, I was thinking about what Serena was saying about the video conference. I think the reason that I use the telephone is, first of all, because I've been doing this for a very long time, starting at when I worked at Kaiser Permanente. We provided a regional service, and so patients couldn't come in a lot of times. So I'm used to using the phone. I think that a lot of times patients prefer using the phone. And so I've just never really made a transition to a video conferencing platform. My understanding is that a landline is HIPAA compliant. And so I wouldn't be opposed to changing my platform. So it works for me, but I'm open to considering maybe sampling some patients and seeing if they would prefer it. I look down a lot. I write a lot because I'm taking family history. And so I feel a little bit awkward if I'm on a video and I'm looking down writing a lot.
Interesting. Dr. Berman?
For me, I think Amy is right that a landline is more secure. So if you have an encryption in your cell phone, or there's some kind of protection in your cell phone, then that's better. But in terms of, for me, for what I do, I can't do it on the phone without face-to-face contact. It just doesn't work for me. So that's I think a personal issue, that when I can be face-to-face with somebody, when I can look them in the eye, when I can see their expressions, that gives me more information for my work. And part of what a big part of what I do is make contact, is make connections. So
Thank you. Dr. Chen?
So for physicians, basically, you're not going to get paid very much for phone consults. We are still struggling to get phone consults reimbursed. And even once they're reimbursed, it's like you get like nothing, like $10. It's ridiculous. So that's why video is very important for physicians. That's one of the big reasons. I also do what Lauren does. Like, I try to read the patient's expressions. Like, when I start talking about things like, so how often do you have sex? You learn a lot by like when you're in front of a couple and how they respond to that. So, you know, that's a big part of how I care for patients and how I counsel them, is to see how they respond to that. So I do think video can be helpful. Now, I have had some patients. I had a patient yesterday. I was like, you know, Jessica, how come, you know, I want to see your face. I miss you. And she was like, Dr. Chen, I haven't dyed my hair. I just couldn't do it, you know. So, you know, you have to be considerate of our patients. I mean, telehealth, you know, now like they don't have to shave their legs before. I never ask people to shave their legs, but all my patients for some reason think they need to shave their legs before they come to see me. And, you know, now they think they need to do their hair. So that's hard, but there's so much you can gain from seeing somebody's face and how they respond, that like I feel like it adds to the visit, like Lauren does. I see what Amy's saying, but Amy, I feel like your concepts are so complicated. We could have a cute like teaching arrangement where you can throw up your screen and have an interactive screen while you're teaching the patient about the chromosomes, because like what, balance translocation, that stuff, it's hard. And then for doctors on a practical level, you know, you need to get paid for what you do. And right now that's the rule, is that you're not paid well, but you're paid the same as in person with that -95 modifier for video visits. And phone consults, they don't care if it's a pandemic. Phone consults are still not paid well.
This is a more practical question. Regarding eye contact, where do you advise looking? If you look at the patient on your screen, you're not looking directly into their eyes, but it's challenging to look at your camera. It looks like Dr. Berman has some thoughts on this.
Yes, I do. Actually, that little Tom Ford slide that I included says that you prop your computer up. I'm going to show you the difference. Hang on a second. I'm going to put the computer down on the desk. So, and then I'm going to put the computer back on the book and put I'm looking directly at the green dot on my Mac. Does it look like I'm making eye contact with you? Yeah. So there are some tricks. We just have some tricks. It actually makes it easier when your screen on your laptop is a little tilted towards you, because then you could look on the screen at your patient at the same time as you're looking into the green dot.
Thank you. Anyone else have a good tip?
So I have to tell you, like I saw Lauren's slide with the setup this morning, and I ran up and got them booked. It makes a huge difference. And I did my phone consult this morning. I did my consults this morning like that. And it changed that whole thing where I felt like I'm looking in the camera, but also at my patient. That was helpful, definitely.
This question is again for Dr. Berman. Is there anything in the mental health world that's not suitable for telehealth?
Yeah, that's a great question. That's what the Telemental Health Task Force is studying. In terms of the fertility counseling world, where there are a lot of things a lot of information that you cannot get, particularly when you're screening, let's say, a gestational carrier. There's information, like when a gestational carrier walks into my office, I can't smell her if she's on, I can't smell her if she's on a video. I can't see where she and her husband are sitting. Let's say in my office, they could sit on separate sides of the room. I can't see how they're dressed. I can only see top up. So there's a lot of information that I am missing when I'm doing a gestational carrier screening on a video screen. There are things that can be worked out. One of the things that can be done, for instance, is we could ask her without warning to take her laptop and show you her house, so we can do a little mini home visit and get information that we'd never get from her coming into the office. So there are ways to be creative, but some things at this point, there are certain psychological assessment instruments that are not standardized and therefore not valid when we're delivering them remotely to someone's home. So those are things but information and regulations are shifting by the hour with the pandemic. So that's to be determined. At this point, I would not personally do remote administration to somebody's home of certain psychological assessment instruments.
Thank you. I'm afraid we have time for only one more question, but I'm going to ask that of the group. There is one member wrote in, my EHR is offering teleconferencing soon. Are you aware of any EHR platforms that are also offering teleconferencing? Go ahead, Dr. Chen.
So I think we are gonna see more and more of this. I think I'm on EIVF, and I think they had sent something to us about this, and it makes a lot of sense to do it directly in your EMR, because you're probably also using your EMR to message your patients. I mean, we use the patient portal, that's a huge form of direct communication with the patient. We're just like, hey, look for it in the portal and all their instructions, their medications, everything to do. It would be nice to have everything all in one place. So I think we're going to see more of that. We're seeing a lot of really cool innovation, and hopefully the regulatory will not be too much of a barrier. This is a great time to do it because it does seem like regulatory is lightening up a little bit. So that would be nice. I think you should encourage your EMR platform to do that. Sounds great.
And there are a couple of platforms that are specific to mental health and counseling that are integrated. So it has EMR, it has diagnostic, patient notes, all kinds of things. And there's a video conferencing platform embedded. So I set myself up recently on one called Simple Practice. And it has, you can choose whether you're going to do an in-person on your calendar. You can choose whether you're going to do an in-person session or a video conferencing session. And it's right there in your calendar as a video conferencing session. It's wonderful.
Thank you very much. Sarah?
All right, thanks, Jessica. Thank you to our panelists. Thank you to our attendees. You will receive a survey by email after this session. Your feedback helps us give you the most relevant content. Your input is absolutely appreciated. This session was recorded, and we will have it available on our website in the near future. Please keep an eye out for the registration email for Tuesday's webinar on coping strategies for laboratory professionals during the COVID pandemic, followed by one on Wednesday by the ASRM COVID-19 Task Force on COVID-19 and Pregnancy, Knowns and Unknowns. For any further questions or comments, please do not hesitate to contact us at webinars@asrm.org. This concludes the webinar. Thank you very much for joining us.